Afternoon, everybody. I hope you're all well and I hope you're all safe. My name is Simon Claridge and I'm the CEO here at Manga. And it really is my pleasure to welcome you all to our discharge planning and rehabilitation webinar this afternoon. As I'm sure many of you are aware, Manga pride ourselves on being specialists not only in post-fall management, but also general mobility, rehabilitation, and supporting people to stay and live in their own homes safely. We've been working with local authorities and occupational therapists for many years now and understand the importance of rehabilitation after hospital discharge to ensure people's home life is not only safe but also sustainable. So the webinar today will therefore focus on hospital discharge, it will focus on the importance of rehab and also the products that support this process. Leading the webinar and presentation this afternoon will be Adam Ferry. Adam is an OT and is director of the OT service. He's going to be presenting for about 30-40 minutes and then we will have a question and answer session. So there is a messaging facility. If you want to use that and you have questions throughout the presentation, please send those in. We've got a team answering those questions in the background. The pertinent questions Adam will answer on the webinar. But they will all be answered today and you will receive a copy of all the questions and answers, and we've got the Manga team here to answer any product related questions as well. So I think that's it from me. Without any further ado, I'm going to hand over to you, Adam.
That's lovely, Simon, thank you. Thank you everyone for joining this afternoon. I know everyone's getting increasingly busy as we've come out of lockdown and our caseloads, our workloads are increasing, and we're having to refocus and services are being changed. So I really appreciate you being here. Before you ask those questions in the Q&A, which is really important to do, but you will all get a link with the live recording of the webinar on. So don't worry if you miss anything I talk about. And at the end, there are a couple of reference slides which include a lot of web links where I'm getting statistics and data from, so you'll be able to click on them directly from what you're sent. So as Simon said, we're going to focus today on discharge planning and rehabilitation, the Covid-19 effect, but within that we're going to be talking about what my experiences are within the acute and rehabilitation services pre-Covid, during Covid, and I know we're still during Covid, but maybe as we're moving, or hopefully moving slightly more out of that very acute phase of hospitalisation. We can only keep our fingers crossed with that, I guess. For those of you who don't know me, I graduated as an occupational therapist in 2007 from Northumbria University. I went straight into a hospital acute-based rotation, so covered the usual hospital-based services. I left the NHS 2 years ago to work full-time and focus my attention on the OT service, which is in the private sector. But towards the end of my NHS stint, I was managing a combination of acute and inpatient rehabilitation services. So this topic is a really good one for me to be imparting some of my experience on. And that's what a lot of this is. So some of the things that I talk about in here aren't, I don't want people to think that I'm expecting them to be your experiences and you've had them in the same way that I've had. That won't be the case. What I've tried to do today is look at some of the current guidance and legislation to reflect on whether it gives a good indication of the things that I've seen and experienced, and how I think that there are challenges moving forward and where I think we can resolve or improve within some of those challenges. So it's very much based on my own experiences. It'll be really interesting to hear in the Q&A whether you share those experiences or whether you have some different experiences, and then you can have those discussions at the end. So the objectives are to reflect on any changes to the hospital discharge process due to COVID-19, to consider the impact on community-based rehabilitation provision, review statutory obligations and implementation of national guidance, and to discuss current challenges of providing community-based rehabilitation and potential solutions. What is often challenging to do with webinars is to pick up on the nuances of an audience and what direction you like a presentation to go in. You get that obviously from a physical presentation, you don't get it from a virtual one. So I have to trust a little bit that the content is what you want to hear, but also as I'm going through the slides, There's some of them that you might find that I've used as a bit of an aid memoir, and therefore me to be able to explore experiences and to talk about some of the challenges that I might have faced. So I hope that is okay for you all. I've put this slide in, and it might seem a little odd to start with, well, what is a hospital discharge? I'm sure we all know what a hospital discharge is. The main reason I've put this in is because the new policy and guidance makes them explicit, and I didn't know there were terms for a complex discharge. Specifically, I've always known that we supported complex discharges, but I'll hold my hands up and say I didn't actually know it was there as this is a non-complex, or in their terminology for this, minimal discharge, and a complex, which is this. They describe a minimal discharge as being if the discharge assessment shows you need little or no care, it's called a minimal discharge, and that a complex discharge is if you need more specialised care after leaving hospital. Your discharge or transfer procedure is referred to as a complex discharge. I find that interesting in that some of the more complex discharges I've ever been involved with haven't involved care. So I think it's interesting the terminology. Now I am certain within those definitions they'll term care as being care and intervention and provision of other things, but I just find it interesting that they specifically use the term care. Often when care is in place, the discharge from our perspective isn't complex at all. It also makes me laugh a little bit because it suggests that every single discharge that we ever get involved in is complex, which I'm sure you'd all probably agree with right now. The other reason I've included the definitions is that there are then detailed expectations for the patient in the event of them being involved in a complex discharge. And they are these. So it says you, as in the patient, should be fully involved in the discharge process. So let's just hold that one for a minute. What does it mean by fully involved? So it gives no details within fully involved about whether that should mean given the opportunity to make informed decisions or just that you're going to be kept up to date. And I'm sure we've all been involved in various qualities of discharge where some patients have been allowed to make very informed, capacitated decisions, even unwise ones, but given a list of options, and others where it's felt like they've been told what's happening. So that it's an interesting starting point. It also says a care plan should include details of the treatment and support they'll get when they're discharged, who will be responsible for providing support and how to contact them, when and how often support will be provided, how the support will be monitored and reviewed, and the name of the person coordinating the care plan. Again, there's that focus on care, so it uses terms like how often the support will be provided, how the support will be monitored. So the terminology does lend itself towards specific care and not things like how is equipment use being monitored, how are moving and handling plans being reviewed, etc., etc. So we're going to look now at what policy says. And in particular, the hospital discharge service policy and operating module, which supersedes the coronavirus COVID-19 hospital discharge service requirements, which was published on March 19th. So this is the new September policy and operating model. It's really important to refer to and look at other things like the Care Act, but I'm not going to focus on that in this particular presentation because I think we by now should be quite au fait with what it says in the Care Act, and we should be able to look that up ourselves and make reference to it within the time we have for this presentation. I think it's really important that we focus on this new operating model because it's something that we might be potentially a little less familiar with, and look at what differences it might support. So within the hospital discharge service policy and operating model, it says that the government has provided funding via the NHS to help cover the cost of post-discharge recovery and support services, rehabilitation and reablement care for up to 6 weeks following discharge from hospital. It says that the discharge to assess model will be fully implemented across England, and we'll come on. I've highlighted discharge to assess because we're going to come on to that in a lot more detail shortly. And it says that social care needs assessments and NHS continuing care assessments of eligibility will recommence from the 1st of September. So from the end of March, CHC assessments were suspended, or continuing healthcare assessments were suspended from a budgetary perspective, and that was to encourage patients to be able to be discharged into places that met their care needs without that need to wait potentially for that funding decision. What it also does, interestingly, is says what patients should be in hospital with. So according to that new guidance, the criteria, it sets out a criteria to reside. So the only people it says who should be in hospital are the people who meet one of these criteria. So requiring ITU or HDU, requiring NIV, requiring IV fluids or medication. They have a diminished level of consciousness. They have acute functional impairment in excess of home community care provision. They're in the last hours of life. They've undergone lower limb surgery within 48 hours and undergone pelvic or abdominal surgery within 72 hours. I've put in bold there the acute functional impairment in excess of home because that's the only one that jumps out as being that's where we come in from a discharge process. What's interesting about the criteria is that it's also the only one that isn't specific or particularly measurable. For example, what exactly is in excess of home care provision? And does that change between localities? And based on particular social care provision? Is there a standard level of impairment that's deemed within the levels of care provision? Because if so, that's not made explicit. So it's the only one that I'm saying isn't particularly measurable. What does it actually mean? I think we all have an idea of what it means, but is it literally, does that level change from one postcode to the next? So from a couple of slides ago, it said that the policy said that discharge to assess would be rolled out across the UK. So it's important that we look at what discharge to assess is. So it defines discharge to assess as where people who are clinically optimised, and we'll come back to that, Tim, who are clinically optimised and do not require an acute hospital bed, but may still require care services, are provided with short-term funded support to be discharged to their own home where appropriate, or another community setting. It includes the assessment for longer-term care and support needs is then undertaken in the most appropriate setting at the right time for that person. Discharge to assess is broken up into 4 different pathways. So it says that 50% of people on a discharge to assess pathway will need no input from health and social care. And the next slide kind of breaks these things down into a little bit more depth about how we determine that. So it says 50% of people coming into hospital will be classed as a simple discharge. The next pathway is 45% of people where they will need some support to recover at home. They're able to return home with support from health or social care. Pathway 2 is 4% of people who require inpatient rehabilitation, so intermediate care. Pathway 3, they say, is 1% of admissions where there's been a life-changing event and home is not an option at point of discharge from the acute setting. It gives more details in the policy about what then the responsibilities are within that. So pathway 0 is the responsibility of an acute discharge staff lead, and pathways 1, 2 and 3 should be led by community health staff. It also says that patients within pathway 1 and 2 should always be allocated some form of case manager or coordinator. So I've broken that down a little there. So the red box, so that's the 50%. So they are pathway 0. So it says that 50% of patients who come into hospital should go home without needing anything, and they are your simple discharge. What's interesting about that box, though, it does say brief assessment of function, for example, transfers and mobility. They're not acutely unwell and they go home. So my certainly my senior acute experience started with an A&E, and I worked in A&E and rapid assessment treatment units for around about 5 years. And typically, they'd be the patients who I would never get referrals for. Otherwise, if you were having to see everybody to determine that they had no needs, it was a physical impossibility. So that brief assessment of function, so for example, transfers and mobility, it doesn't say who that's carried out by. My experience would suggest that rather than it saying brief assessment, it's more of a triage. So by a member of the nursing team who, as part of a handover, will have said, no, they're independently mobile, transferring independently, they don't need to see you. My guess is that's what it means by that, rather than as a formalised assessment. Otherwise, I don't know where we get the resources from to see that group of patients. The 45% though that you can see there are where I would say typically in my experience, my acute experience, certainly with an A&E and front of house work, is where we would get involved. So they are patients who require something. And you can see from that graph, it could just be anything. So it says signposting and advocacy, equipment, enablement, ongoing health intervention, access to community beds, ongoing review of care needs, etc., etc. So, things like signposting and advocacy, it's tough because they're, in my experience, a group that would probably have been put into the 50% we've already discussed. So if somebody didn't need an immediate physical response, we might have provided them with some information about how to move forward. This is putting them in that 45% of discharge to assess, and that might also mirror my experiences around how discharges to assess is used and where the statistics about who is involved in discharge to assess and the success of discharge to assess comes from. But it's interesting to see how they break that down. It's also interesting to see when it says review of care needs, it's less explicit there about who does that, when they do it, how they do it. But we'll come on to that shortly. The rationale within the document for discharge to assess uses this quite emotive case, I guess, and I'm interested to know what your thoughts are. And it says, imagine leaving your home abruptly and never returning to it again. This is what happens to people every day because we assess people in a place that is not their normal environment. And I've put a little graphic in there. How do we feel about that statement? I read that and I thought, I'm not sure if that represents my views about what hospital assessments were like pre-discharge to assess. And I think, and I'm a fan of discharge to assess when it's done right. But what I'm saying is, my experience doesn't suggest that we were assessing people and saying somebody couldn't go home because they were being assessed in the wrong environment. In fact, for all of my years in acute services, I can't remember ever telling somebody where they could and couldn't go. I saw it as my job to assess risk, minimize that risk, and afford somebody the opportunity to make educated decisions. But they've used this as a way, I think, the whole thing reads as quite an emotive piece to say that this is what is happening in healthcare. It'd be really interesting to know what your experiences are. It would even use the term because we assess people in a place that is not their normal environment. I'd like to think that healthcare professionals, and I'm an occupational therapist, so I'll speak as an occupational therapist. As an occupational therapist, I'd like to think that I have enough awareness about how somebody's function can change in a different environment to be able to determine whether somebody then needs to be assessed in their own environment, whether it'll make a difference or not. And I certainly wouldn't jump to the point of somebody can't go home because we're assessing them here and this assessment shows that they're unsafe. So I'm not sure how you feel about that statement. I also say, so when I was working in the NHS, we started implementing a discharge to assess model around 3 years before I left, maybe 2 years. So we're looking at 3 to 4 years ago from now anyway. So although it's nothing new for some trusts or local authorities, is it just that the increased rollout and the focus demonstrates the pressure on services to discharge patients quickly? I feel like discharge to assess is as a notion has been around for quite some time now, certainly a few years. So rather than saying it's something new, I feel like, is it something that is now being refocused on during, certainly since March, because there's been that increased impetus of getting people out of an acute environment. Be interesting to know what other people's experiences of that discharge to assess are, and whether things have changed within that process over the last few months. So what has changed since March? The delayed transfer of care data was suspended on the 19th of March. So I don't know about yourselves, but certainly in the couple of years when I was managing services before I left the NHS, we had to every single day gather data about why somebody was in hospital. So we had delayed transfer of care meetings where anybody who had been in hospital for over a period of time, and sometimes it wasn't very long at all, we had to say why they were still there. And it was my job to say that from a therapy perspective, why that person was still in hospital, as if we were justifying why they were still there. Those figures were suspended on the 19th of March, but they were replaced by something slightly different, which you could say amounted to a similar thing, but with a different focus. So it was less about why are they still here, and more about gathering information about just the people who were there and what their needs were. There's a 95% target for home-based assessments within discharge to assess set. I don't know where it's required. So within that 45% of patients who would go home via a discharge to assess model, the target is 95% of those that patient group will have purely home-based assessments. And I might be wrong, but I don't recall that being a set target when I was in the NHS. Certainly 2 years ago. So unless that came into place within the last year, I think this is new from this document. It says that £588 million has been made available to the NHS to support 6 weeks of additional support from the 1st of September. I've put a star there because, probably for obvious reasons, I've done a lot of research into this money and to what it means, and I can't tell whether this is £588 million additionally made available to support the NHS, whether it's part of the £3 billion that was given to the NHS or Department of Health as part of the COVID fund, or if it's something completely new. Nor can I tell when it says 6 weeks of additional support, whether it means it's just the 6 weeks that was previously available, or whether there is literally an additional 6 weeks support available. So effectively people could get 12. My guess is that it isn't 12 and it's still 6, and that it's additional support in terms of resources and flexibility for people who may have previously needed it and didn't and weren't able to access it. But it's very difficult to tell from those figures and from the documents that discuss it. Some of you might know a little more about that. There's been a lot of redeployment of healthcare staff to minimise length of stay in a hospital or need for admission in the community. So some of you who are on the webinar, and I've got friends in clinical services and the NHS who've been moved from services such as rheumatology clinics and moved to ward-based therapists in an attempt to hasten the discharge process, or certainly make it smoother. My understanding, certainly from speaking to previous colleagues and to my friends, is that that is starting to loosen, and that some of them are going back to their substantive posts. But that must have been a real challenge for those people to have been put into those settings where they weren't familiar with and expected to support those services. Hopefully, we're starting to find a little bit of normality there, but again, the therapists and healthcare professionals on this webinar, you might be able to let us know what your experiences are of that. And I've put inpatient rehabilitation there because of what we're going to come on to next. But I worked in inpatient rehabilitation for a number of years, and like I say, managed a couple of inpatient intermediate care wards towards the end of my NHS career. And it looks to me from the outside and from this documentation as though inpatient rehabilitation the focus has changed quite significantly. Because it suggests this. So what it says, even within community hospitals, intermediate care settings, is what we should be asking is why is the person not at home? What needs to be different to make this possible at home? And why is that not happening today? And that's not to say I don't understand those questions, because I absolutely do, and we should be getting people home in a timely manner. But it to me seems like that discharge to assess model or focus within inpatient intermediate care settings, there's a challenge there that we lose the determining and actioning of rehab potential. Because if we don't have the resources to manage a more intensive rehab program at home, then is it not right that those patients have the opportunity to maximize that potential in an environment that makes it possible? That's not to say you couldn't answer those questions in that way. So why not home? There aren't the community resources to manage that person's rehab. What needs to be different to make this possible at home? We might not be able to affect the amount of the community resources, but we might be able to improve the person's functional level and mobility level within this environment, which then makes the resources available at home. And why not today? Because we're working through an ongoing rehab plan. So I completely get how that works, but it feels to me through the document and through the guidance that there is an overwhelming shift which questions the need for inpatient rehabilitation for a large patient group. Again, it'd be really interesting to know what your experiences are with that. So what are the current challenges with discharge to assess? So, and again, these are my experiences, yours might be completely different, but generic working was a significant challenge for me and my team in particular, where there appears to be what's the best way of describing this? A jack of all trades group. So everybody is a jack of all trades, and there are small elements of your specialisms that you may be able to use within certain cases or within certain caseloads. And that, or as much as I understand it, because it may be efficient, I think professionally is a real challenge. And how we come to terms with a greater generacy is definitely a challenge, and I think we need to continually reflect on what our roles within our protected titles are and how we apply them, even if it's within that generic team or that generic role. I find the term medically optimized a challenge because, again, in my experience, that changes depending on which consultant you might be working with or for, or what locality I might be working in, what service I might be working in. It seems to mean very different things. So it was very different to say, for example, when I was working with a geriatrician, medically optimized meant something very different. I always felt like a geriatrician was looking at somebody holistically. They were paying as much attention to function as they were to cardiology, for example, or to orthopedics. They were looking at the person very holistically. But when my patient was under a cardiologist, say, for example, medically optimized to them meant when there was nothing else that the person needed for their heart as an inpatient. So the challenge there is what do we mean by optimized? Interestingly, again, the guidance says that people aren't to use the terms such as medically fit or medically ready. They must use the term medically optimized because that infers something different. 7-day working was a huge challenge within discharge to assess for me and for us and my teams, in that, let's be honest, in most services it isn't 7-day working. You've got your Monday to Friday and then a skeleton Saturday and Sunday. With changes in community resources, that was a big challenge. So how do you how do people go through the same pathways 7 days a week and have the same opportunities, and how do we make the same decisions at those times when resources aren't growing? You just expected to stretch them over 7 days. I'm sure those discussions have been had by every healthcare professional whose services have moved to 7 days. But I think within the discharge to assess model, for me, it's just highlighted a little further. And managing risk and delivery of reablement all linked to that other one of resources, community resources. So I think there are different perceived risks of somebody leaving hospital with very minimal assessment for those risks to then be managed at home. But then on reflection, that's probably because certainly in the areas that I've worked in, we've been dubious or unsure of whether the community resources could meet that challenge. But basically, were there enough people to have that person, to meet that person at home and identify those risks and manage those risks immediately? And we often queried, yes, discharge to assess is fantastic for the right people, completely agree, but actually for those patients who we were just going to spend a small amount of time with, put some things like equipment in place to support that safe discharge. Actually, was that not just more efficient for us just to spend that small amount of time with the patient, make our recommendations, get them in place and get the patient home? And that could have been on the same day. It doesn't necessarily mean that it was a different day, but our experience of how discharge to assess was rolled out was quite different to that, where it was, no, you won't do that at home. Sorry, you won't do that here. The person's just going to go home, and we'll get somebody there within a short period of time to do those assessments at home and get it sorted. And I often couldn't get my head around, why can't I just sort that now? That might be something that's changed, and community resources might be fantastic. But I'm certain that there are pockets where community resources are still limited, where I think services need to look at actually what is the most efficient. Within community resources, again, it's access to equipment. It's not just about people. What can you get at certain days or at certain times of day? What can't you? And certainly delivery of reablement is so how frequently is it going to happen? How is it going to be reviewed, etc., etc. So rehabilitation itself, so RCOT define it as the provision of personalised support to enable people to recover from periods of physical and mental ill health. They say that rehabilitation ranges from supporting people to manage long-term health conditions and disabilities through primary care services to acute hospital settings, preparing people to return home and back to their local community. So it's that full cycle of in the home, if they need to come to hospital, it's from primary care to acute services, return back home and be back in their community. But what is it that people should expect from rehabilitation? So the NHS Constitution pledges to provide a comprehensive healthcare system to meet individuals' needs, prevent and improve mental and physical health problems, promote equality, and for this to be universal and free of charge. That's a fantastic statement, but does it always happen? And is it the reality? Is it the reality? Has that reality changed in the last few months or not? Maybe not, but there are certainly challenges. So I have a recent experience of a hospital discharge professionally, where I was actually supporting within the private sector, but the person was obviously seeing the healthcare professionals who were ward based, and it was a lady who had dementia and had been moved from in between a few sites within the hospital. So you can imagine somebody comes into a hyperacute unit for assessment initially when they're first brought in on an ambulance. Then they were moved to a subacute site, and then they were moved to a community site, which wasn't intermediate care. It was ward based, but it was like it was seen as a step down, but there was no real therapy involved. So this person had a relatively advanced dementia. And then on the back of that, as part of the discharge plan, so this person was going into a care home as part of this, so there'd been a lot of challenges at home and lots of things had been tried, and it was just the case that on this particular discharge the person was going into 24-hour care. But after 3 moves, it was decided by the hospital ward that because the placement wasn't going to be ready for another 24 hours, that the person could go to a temporary placement for 1 night whilst the long-term placement was arranged. And obviously those things got stopped, but it makes me wonder if we're saying that the NHS Constitution pledges to provide a comprehensive healthcare system to meet individual needs, prevent and improve mental and physical health problems, promoting equality, then in this particular case, actually was somebody being relatively dismissed because they were elderly, had dementia, quite frail, and were going into a place where their care needs were going to be completely met? And I think the answer is probably yes. And I think we've all probably seen that if we've been on wards or even in our personal experiences, I think we've all probably witnessed it. So is the NHS Constitution therefore being upheld and doing what it needs to, is my question. The NICE guideline NG74, which is from intermediate care, including reablement, says that rehabilitation is a range of integrated services that promote faster recovery from illness, prevent unnecessary acute hospital admissions and premature admissions to long-term care. They support timely discharge from hospital and maximise independent living. I think in theory we could all share that that's what that is. It says that intermediate care services, we're still on the NICE guidelines here. So it says that intermediate care services are usually delivered for no longer than 6 weeks and often for as little as 1 to 2 weeks. I've highlighted usually there because actually within the guidance and so within the policy and the NICE guidance, it doesn't say for 6 weeks. It says they are usually delivered for no longer than 6 weeks. I wonder why clinically that 6 weeks was stipulated or advised, and the cynical part of me thinks it's probably financially focused and not rehab or clinically focused, because I've seen people within the private sector who have had their 6 weeks of rehabilitation, have presumed that that's it, and then a year later have said, actually, I think I could probably do with this, so I think I may be able to achieve more, and have certainly continued to have significant levels of rehab potential and have continued to improve. What I do want to highlight, though, is that it says usually delivered for no longer than 6 weeks, but it does also say in point 1.6.1 that we must take a flexible, outcomes-focused approach to delivering intermediate care that is tailored to the person's social, emotional, and cognitive and communication needs and abilities. So nowhere does it say that we can't argue for more than 6 weeks of intermediate care, home-based reablement, if it's what we can demonstrate that person needs. And with the additional funding that it says is in place, in theory, there should be the resources there to meet that need. So if that's the legislative and the guidance expectation, what was the pre-COVID reality? So these are pre-COVID statistics. So they show that only 15, and sorry, before the links to all these statistics are in the references at the end, so you'll be able just to click on them and see where I got them from. So they say that only 15% of people with lung disease deemed eligible for pulmonary rehabilitation are referred for it, pre-COVID. Only half of people can access cardiac rehabilitation after a cardiac event, and this rate is lower for women, BME and economically deprived patients. It says that after a hip fracture operation, only 1 in 5 services provide people with rehabilitation on discharge from hospital, despite evidence that it's what best aids recovery. Falls prevention services are a postcode lottery. If everywhere provided high quality falls prevention support, 29,000 injuries, it's estimated, due to falls in older people could be prevented every year. So if any of you who are involved in fall services, physiotherapists in gait and balance classes, all of those healthcare professionals who are involved in some form of reablement, that one's really pertinent for yourselves. And it says that 44% of people with neurological conditions don't have access to community rehabilitation for their condition. 22 of them would like psychological therapy and 13 would like physiotherapy but can't get it. Actually, the neurological one was the one that I was most surprised with, because having worked in, my clinical specialism is neurology, and in my experience, neurology is actually the area that I found has been the best from a both inpatient and from a community-based rehabilitation and reablement service. But it may just be that, again, that they're the postcodes that I'm working in, and it may just be that the services are set up around stroke and neurological recovery. Your experiences might be quite different. Those statistics are pretty stark, and that's pre-COVID. So now we're in the middle of COVID, and hopefully coming out of it in the near future. Rehabilitation is vital to the recovery of the nation from the crisis of COVID-19. RCOT say that they expect significant increase in demand for high quality rehabilitation services to ensure people are able to return to their lives and fulfil their roles and responsibilities. So if we're having such a challenge with rehab and reablement pre-COVID, what is that going to mean for us now? It's certainly not going to get any easier. Some things that I think are the current challenges. Determining rehab potential. I've put that at the top because I think it is a huge area for discussion. I was often asked, sometimes after 5 minutes with a patient coming in A&E, what their rehab potential was. How do we, how much reablement do they need? With statements along the lines of, but they're limited in this way, so it's probably not going to be achievable. So let's think about this. We were asked to make decisions about rehab potential in a snapshot, and I would hope most of our responses are, well, everybody has rehab potential in some form. It's what is the impact of that rehab and reablement going to take? So now, if there is an even greater challenge on getting people out of hospital, and in particular for this point, intermediate care, inpatient services, through discharge to assess, to use community-based resources, I can see how determining potential and setting rehab goals is going to be potentially an even bigger challenge. Although the goal setting is obviously incredibly important, we need to be really careful about determining rehab potential. One of my former lecturers, a brilliant OT called Gemma Bradley, who's a lecturer at Northumbria University, has done her doctorate on determining rehab potential, and it's absolutely fascinating. Therapy provision in terms of resources is a huge challenge because of everything else we've said. If more people are going to be coming out of hospital more quickly and identified as needing reablement, where does it come from? It's all right identifying the need, but where does that come from? The review process for reablement. So the idea is that reablement is provided and you're reviewing somebody's needs to minimise the need for long-term care and maximise independence and engagement and meaningful activity. As I guess as occupational therapists, that's what we should be doing. But who does that review? Does that need to be by a therapist? If so, where are we getting all these therapists to do that from? If it's from non-therapists, then are we making sure that those people have the knowledge and the skill to be able to make those determined decisions? And that leads into knowledge and skill of workforce, specifically for reablement. Again, this is just my experience, but when my trust first developed a community reablement service, it effectively took over an in-house care service. And those carers overnight became reablement workers. And I'm not entirely sure what level of training somebody then needs to be able to move from care in terms of doing for to reablement, where we are being much more objective and taking a step back. One of the current challenges is obviously the infection control and transmission risk reduction in a time where we're told to be minimising our contact. So it's minimising our contact whilst maximising reablement, which seems like a challenge in itself. So what do we do about it? So politically, we need to commit to high quality, accessible community rehabilitation services in our manifesto or in our service plans. We need to lobby for the amendment of the NHS Constitution to make people's existing rights to community rehabilitation clearer and more explicit as a key part of a comprehensive healthcare system. And we need to use the NHS accountability framework to mandate NHS England and the other arm's length bodies to use promised increases in funding to deliver this. I think sometimes as occupational therapists or as healthcare professionals, we feel like we're stuck within our boundaries, but we need to get involved politically, push for these things. And wherever there is a challenge, there is an opportunity. So that says crisis and opportunity. I hope it's more challenge and opportunity, although sometimes certainly over the last 4 or 5 months, it has felt a little bit more like a crisis. But where there are challenges, there are opportunities. So what are they? I'm sure all of you have used technology more in the last few months by use of virtual or remote tools, and we certainly have as a business. So we've been doing a lot more virtual assessments. I think healthcare trusts have still got a little bit of catching up to do to see what's safe and what's efficient and effective, but certainly it's become much more accepted and widely used as an assessment tool. And there's been quite a lot about that, obviously, in the last few months for people to watch and look at. There's an opportunity to forward the therapy agenda. An awful lot in the media, obviously at the minute, about rehab and COVID recovery. Let's use that demand by a way of saying, hello, here we are, this is what we do, and this is what we can help with. And the other thing about the therapy agenda is, I guess never has there been a time more where we shouldn't have to explain occupational deprivation more. Describe it less, because everybody has been deprived occupationally in their ability to engage in meaningful activity over the last few months. But that is what some people live with every day as part of their disability. Now should be the time where we can say, you know how you felt in the middle of April, the end of April, when you felt like you couldn't do anything. Okay, now imagine that for the next 15 years, 20 years of your life. Now will you let me do something to help that person about it? So we should be using that agenda to say, this is what we do, this is what we're good at, this is how we can save you money, and this is how we can impact on people's long-term health and well-being. Developed an occupational therapy role within the acute environment. I often felt like my team was saying they were discharge planners, discharge assessors rather than occupational therapy. I think within discharge to assess, because there's a lot more within the home environment, I think there's, as much as it's a challenge, I think there's a real opportunity there for us to go back to our roots and say, yeah, we accept that that is where people need to be assessed predominantly within their home environment where they're familiar with, and this is how we can use our specialist skills to support that and make sure that even if it's a mindset or even if it's how we just use our documentation, that we're ensuring that we're reinforcing that specialist occupational therapy role, even if it's within some level of generic working. And definitely the use of assistive technology for risk, well-being and independence. I think it's something we've been very good at from a safety perspective within discharge. So we provide equipment to manage risk within safety, but it's not my experience that we've used it very well from a reablement perspective. And you can use these sorts of equipment to support reablement. So it's not just about raising a chair to help somebody stand up. It's actually, if that person might not need anything, can we use equipment and grade that equipment so that they're needing to use more effort as the days or weeks go on, and somebody within reablement is reviewing that, even if that's virtually. What a great efficient way to manage independence. And that's, you know, an excellent use of assistive technology. The same thing for a bed transfer. So rather than somebody going in to help somebody get into bed, is there equipment that we can use, or is there assistive technology that we can use, not just for them to use forever, although some people might need to use things forever, but can we use it within reablement? So can we use it to grade those programs whilst accepting that somebody doesn't need to be there all the time to work on the person with it? Exactly the same for bed mobility. Some people might use these sorts of cushions forever, but some might just need things as part of that reablement or rehabilitation program. So we've been very good at using them to manage risk. Maybe we need to start thinking more about how do we use assistive technology to support rehab or reablement programs. I'll quickly just summarise because I'm at 45 minutes. So to summarise, COVID-19 may have only exacerbated or highlight challenges in some cases. So it's to say some of the things that I've talked about, I think were happening anyway, and it might just be that COVID-19 has highlighted them or exacerbated them, or made us more aware of the gaps that we have in services or resources. Current policy supports individual, personalised, flexible care and reablement, but resources often make that challenging. And there is an opportunity to improve services through virtual means and the use of assistive technology. I've got lots of references on there for you to use and to click on, which you'll all get as part of the link or the presentation that you'll be sent. Race through those last couple of slides just so we can get to some questions. But thank you so much for listening. I hope that what was being talked about has been a good starting point, at least for people to be able to then go to these policies and have a look for themselves. But it's been lovely to be able to give an opportunity to present to you. So thank you once again. Thank you very much for attending. I'll hand you back to Claire for some questions.
Thank you, Adam. That was really interesting. We have got some questions which I think we're going to put to your co-director at the OT Service, Kate Sheehan. Kate, I think we heard a lot from Adam there about how COVID had very much focused people's minds on having a good discharge from hospital, a robust discharge and care pathway, and that the role of occupational therapists are going to become so much more important, particularly in sort of avoiding readmission rates. And I just wondered, when you look at this in practice, you know, what do you think your biggest challenges are over the next 12 to 18 months? One of the questions here is about, has your caseload already increased on the back of COVID? You know, are you seeing similar case loads that the NHS has, for instance?
I think what we need to do is go back to, you know, what are our challenges and what is a safe discharge? And I think for us, a safe discharge is putting the person at the centre. And often in these times or unprecedented times in the pandemic is we often forget the person. We forget that the patient is a human being, and a human being is not just about a physical ailment. It's not about a hip replacement. It's not about a stroke. It's about what they do and what they are as a human being. So we must never, ever forget that. I think there's also the issues around the best kind of form of discharge. And I think we've probably failed a little bit in the pandemic, is effective communication. And again, effective communication, not just with the kind of care providers, as Adam said in his talk around communicating with social care and care agencies, but it's communicating with the client themselves, what do they want, but it's communicating with their family or their own informal carers. And I think we mustn't forget communication. It's about getting equipment in place, but the right equipment in place. And sometimes I personally get frustrated when I'm working in conjunction with social carers that they have limited equipment provision. So, you know, they might have one pillow lift, or they might have one leg lift, or they might have one bed available. But actually what we need to do is make sure that equipment is actually fit for purpose for that individual to provide that safe discharge. And I think, again, it's about trying to get that rehab in place at home at the right time. And it's difficult with cross-infection, but what we're going to end up with is people who are more disabled than they need to be if we don't provide that care at the right time and at the right place.
Thanks, Kate. And the next question sort of follows on from that, really, in that from what we've heard, this discharge process really seems to involve quite a range of clinicians across the board, depending on the patient and the situation, obviously. But who's ultimately responsible for a successful discharge and reablement, and what does that look like? What does success look like in this situation?
A safe discharge is the responsibility of everybody. It's a multidisciplinary team working with the client and working with their family and carers. I think as soon as you take people out of that team and don't allow everybody to have an involvement in it, you get some sort of breakdown. But I still come back to the most important person is the client. If we've got the client on board and they're engaged about their discharge, they feel safe, secure that their discharge is going to be in their own best interests, then that's a good starting point. But we must work as a team. If we don't work as a team, then that's when you have an unsafe discharge. And I just, maybe another plea is, we certainly, as a practice, have seen an increase in referrals from private individuals wanting additional input for their loved ones. And we need to work across the kind of statutory services and private services to meet the needs of our clients. And that's not a bad thing. We just need to work together.
Okay, I think that's interesting, because can I now put some questions to Andrew McPhail from Manga, because I think this carries on from what Kate was just saying, in that Manga, next year will be our 40-year anniversary. We've been working with assistive equipment all that time, and our priority has always been about working with OTs and supporting OTs. But COVID has had an impact on that. And I think, Andrew, what we would like to ask you is how you and your team are still able to support OTs in the current environment.
Yes, the team here at Manga have continued to provide demonstrations, training and support throughout the pandemic. We've obviously had a lot to learn about PPE and extra cleaning measures to make sure the OT, the service user and the staff are safe. We continue to support OTs and the service users by doing joint assessments, both in person and virtually. Some visits, for example, we've had to undertake without the OT in person, but the OT has been dialed in via FaceTime, Skype, Teams, WhatsApp, Zoom, Ring Central, and every other platform that you can think of. Others, we've been actually in our own home, showing the equipment to the OT virtually, so they can understand how it would work and how it would benefit their client. But of course, we continue to do face-to-face demonstrations as well. I've personally, there's been a lot of talk, has the caseload increased? I've personally been doing a lot more demonstrations, and you can see firsthand what the difference an assessment makes. Last week I was in a caravan doing an ELT demonstration with an OT, as the client was desperate to go away, but their holiday had been cancelled, so they bought the caravan. But when they were trying it out, one of the persons kept falling over in the caravan, and it's a tight space. So the OT came out with the ELK, and we demonstrated the ELK. It was wonderful to see that the joy that they continue to use their caravan without being, the worry of being left on the floor. We've also seen an increase in demonstrations in hospital wards to facilitate the quicker discharge of patients. There does seem to be a lot more joined up thinking, which has been positive between OTs, but we're still very much here to help, Claire.
Okay, and then also carrying on from something Kate sort of mentioned, informal carers, and I just wanted you really sort of, in your experience, what questions and concerns are you getting from those people who are actually probably charged with looking after their loved one, to support them when they've been discharged from hospital? What sort of concerns are you seeing? Yeah,
initially there was obviously a lot of concern about how we can undertake joint assessments safely. And we had to run through our PPE and cleaning protocols and give assurance that this was to the highest standards. Another concern was about having the ambulance service come into their own home to pick people up from the floor. So this was the point of view, number one, not to bother the ambulance service, but also number two, so that, basically stop people entering their home that didn't have to. So we've been busy supporting OTs and carers dealing with falls. On the same vein as this, we've seen people who don't want carers coming in now to help them into bed. So we've been really busy with our leg lifters, as people don't want carers coming in to lift their legs into bed. So in some ways, it's pushing people to go down the independent living route, which we think is great. One of the biggest concerns from individuals we meet after they've seen the product is actually how quickly can they get the product, and are we still manufacturing? Our production team have been amazing, to be honest, during the pandemic, working in a different way, and but we still manufacture our products every single day. They are so keen to get out of hospital that they're delighted when we say it's the paperwork that'll take the longest and we'll get the product to you the next day. Another concern is the support, what happens if they have questions. So we direct people to our website or call us. But I think credit also has to be given to the OTs. You know, we've had laptops and things balancing on mantelpieces and phones balancing on mantelpieces, dialing the OTs in so they can see it. And finally, that the OT teams seem to be communicating better together, being honest. I hope people don't mind me saying that, but when we're in an area now, we're doing 4 or 5 visits with the same OT team rather than visits separated out across the 2 weeks.
Thanks, Andrew. I think our time is up. We're up about an hour, so I'm just going to hand back to Simon to summarise.
Yeah, no, thank you, Claire. I think in the interest of time, we're at 3 o'clock, aren't we? So I'll make this brief. Firstly, just a big thank you to you, Adam, for an excellent and informative presentation. Some really good examples and sharing your experience I found really, really interesting. Thanks also, Kate, for being online and for your support with the Q&A. And for everyone for attending the webinar. Hope you found it useful. As I said, you will get a summary of all the questions and answers, so that will be sent out to everyone probably next week. You'll also receive a copy of the presentation, so you'll have that in case you didn't take all the bits and pieces down. So again, yeah, thanks for listening. Thanks, guys, and please join our next webinar. Cheers.